around how you manage COVID at home to reduce inappropriate admissions to hospital and also get people out early using virtual care and remote monitoring. We've just published a paper today. I'll share the link in chat.
Okay, great.
That or actually, before we start, can I share my screen? No. Will you let me share my screen at all?
I think it's already 6, Professor Matt. I would love to, can we have this just after the call, if you don't mind?
Okay.
Great, thank you. So in just for the information, so this is open QA sessions, and as we promised all of our participants that they can ask any question beyond the topic or anything, but it has to be related to COVID-19. So that's just for the information for all of our speakers. I think we are live now. We can start. Great. Just give me 1 minute. Thank you. So, dear participants, I, Deep Narayan, would like to welcome you all in the UK-India Clinician Knowledge Exchange series. Today, we are holding the second open Q&A session on COVID management pathways. This is one of its own kind, where top experts from NHS will answer your queries based on their knowledge and experience of COVID management. I'm delightful to share that we'll be holding these sessions on every Thursday, 6 p.m. and series of webinar on every Saturday at 6 p.m. We encourage all of our Indian clinicians, medical students, and other medical professionals working in the forefront of COVID management to participate in these sessions. You can ask your questions using the YouTube chats. In the interest of time, allow me to welcome our excellent moderator, Dr. Chetan Dhamne. Dr. Chetan is an assistant professor of Paediatrics Oncology at Tata Memorial Hospital. He was a consultant at National University Hospital, Singapore, and a clinical fellow at MD Anderson Cancer Center, Houston, USA. His research interest includes pediatric leukemia and immunotherapy. I would request Dr. Chetan to open the session and share his thoughts. Over to you, Dr. Chetan.
Welcome, everyone. I'm sure you're all excited to join this session so that you can really hear what needs to be done from the horse's mouth, rather than listening to so much confusion and chaos that is going on around with lots of information going on. And you really don't know which one is right, which one is wrong, and pathways keep changing. So we would like to get our experts, Dr. Matthew and Prof. Nick from NHS, to answer these questions for you. So we have, this is our second session of question and answers, and initially we had covered a little bit on COVID management in mild to moderate disease. And Prof. Nick had also given us a seminar or a webinar on mild and moderate COVID disease. But you are free to ask any questions you would like related to COVID, as long as we can answer them to the best of our ability. Okay, and you can ask any questions, as I said, but keep them restricted to COVID. It can also include prevention and management. Also, we would like to get our experts to weigh in on how we can prevent or manage the next wave to come. So those questions are also welcome. With that, I think I would like to invite Prof. Matthew to put forth his thoughts on COVID management, and then after Prof. Nick and Prof. Matthew had their introductions, we will open the session for questions and answers. Over to you, Prof. Matthew.
Thank you very much, and I'm honoured to be part of this. And can I just start by saying it's all countries that face the same challenge of disinformation against believing the science and evidence versus what others are doing. And COVID has forced a lot of panic on everyone. And we are sometimes doing inappropriate things, not because we are bad, but because pressure and the situation sometimes dictates it. And it is very difficult and challenging sometimes to get back to the science and what we should really be doing. And it is not a problem in India alone. It is the whole world over. In terms of, I guess, the excellent talk Nick gave last week, which really focused minds on what we should be doing with mild and moderate patients, the bulk of what we see within COVID. It opens the door potentially, building on Nick's excellent work of what we might do in the patient's own home before they get sick enough to come in with COVID. And it would be great in due course to share some of the early evidence we've just published today in a pre-publication about the impact that monitoring patients at home with a combination of symptom diaries, oximetry diaries, and telehealthcare can do to both prevent admissions, to expedite early admission if patients deteriorate significantly with COVID in the community, and the impact that has on reducing bed occupancy in hospitals and improving the flow through the emergency care sector, as well as a large reduction in mortality rates, intensive care admissions, and future readmissions. So it would be really great to explore that in due course. I'm very happy to put the links in the chat. So thank you. And this collaboration between India and England is really an incredible thing. And I think we've all been on quite a few webinars now between our two great countries. And I, for one, am learning more from India than I think the other way around. And in one of the places we began doing remote monitoring webinars, which was the System 1 system, they now are looking after patients with COVID across 16 states and onboard 400,000 patients currently with COVID using remote monitoring and pulse oximetry. They are onboarding 85,000 new patients a day through their 7,000 voluntary doctors workforce, as well as allied healthcare professionals. So it would be fantastic if we can pool our data together to really prove the model at scale. The World Health Organization has also got a living guidance that recommends the use of remote monitoring and pulse oximetry now internationally. And there is a chapter that is in evolution to try and describe this in a way that can be disseminated and spread. What we need to remember through all of this in preventing third wave, fourth wave, and our healthcare systems being completely overwhelmed, that it is not one sector that has all the answers. This is about prevention. This is about good management in the community, as well as what we do within the hospital sector. But the hospital sector is only a very tiny proportion of what we need to be doing. So the great strides in vaccination, in ventilation, aeration, and prevention of transmission amongst patients and the general public is critical, followed by what you do to manage mild COVID in the home. Because if we can get those two things right, then we are not going to overwhelm hospitals. So with that, I'd like to hand the baton back to you. And thank you so much for letting me join you today.
Thank you so much, Dr. Matt. I think this was very well said. Now I would like to introduce to Professor Nicholas Hart. He's a clinical director, respiratory sleep critical care LAN, director of research delivery Guy's and St. Thomas NHS Foundation Trust, London, professor of respiratory and critical care medicine, King's College, London, and joint editor-in-chief, Thorax, Journal of British Thoracic Society. I would request Professor Hart to share his thoughts. Over to you, Professor Hart.
Deep, thank you. And Matt very eloquently said, and Chetan, it's really lovely to see you again. And by the time we finish these webinars, we're all going to be best friends and we're going to see each other in person in due course. And I think that's what we've got to focus on. So I'd just like to say these webinars are exceptionally important. They're exceptionally important for us to get simple messages out. And I think you heard that from Matt, and simple messages that need to get out to many folk. And if we can get these out, it will allow more patients to receive high quality care and the quality care that all patients deserve. So looking forward to the questions today. Looking forward to seeing everybody next week as well, because I think I and Matt have signed up for this. So it's us in for the long haul. So Chetan, sorry, but we're going to be here and chatting to you and Deep for a few weeks to come.
Oh, that's a pleasure actually. So pleasure and an honor. So great. We'll go ahead and we are already discussing about how to manage COVID at home. We have discussed about moderate disease. So the other question that comes up always is when do you transfer the patient to the ICU? So now you have a patient who is on oxygen, who is on dexamethasone, who is on anticoagulants, he is on oxygen. So what is the tipping point that would say that this patient should go to the ICU? And the next subsequent question would be, when does this patient need ventilation? Non-invasive followed by invasive ventilation.
Matt, shall I go first? And then so the way we approach this, Chetan, we were a hospital which has a very large critical care structure. And because we have a very large critical care structure, it allows us to approach this in a way that we felt was the right approach. You'll hear a number of elements in the discussion around escalation to respiratory support, non-invasive respiratory support, to advanced respiratory support, and even in some cases, you know, to management of severe respiratory failure with ECMO. And we have facilities to do that across in our institution. And just taking on the point of the patients that are super sick and super ill, the ECMO, during the 2 waves, we saw 117 patients who required ECMO that came through. But taking that aside, what I'm interested in is the timely transfer to critical care. And I think that's really key. And the things that came out when I was having these discussions, Chetan, is how different the systems are in the UK and India in terms of, and I'm going to highlight this because it struck me in terms of radiology. So there'll be a CT scan done and it'll be scored, and then the patient may move to a critical care environment because of their imaging. Whereas for me, this is like an atypical pneumonia. If I've got someone who's got an awful imaging, I want to see the patient. I want to touch the patient. I want to talk to the patient. So symptoms of the patient, signs, and those basic investigations are much bigger drivers than an imaging identification of acute lung injury. You know, we've all seen acute lung injury. We've all seen COVID acute lung injury. We know what it looks like. So that has to be clear. What is the functional impact, physiological impact on the patient is far more. Now, we will be targeting folk for saturations within the range of 92 to 94%. It's very difficult to set one target range, but you set a range. Now, when we had patients that we were concerned about, and we didn't use as our first line, in essence, non-invasive respiratory support, because our view was of patients coming in for us, they were 50 plus years of age, 50 plus years of age with diabetes and hypertension, 50 plus years of age, diabetes and hypertension with an acute lung injury, which was so severe that on 15 litres of oxygen, I can't maintain their SATs above 92%. Well, that for me, do I immediately jump to giving someone non-invasive respiratory support? Well, very rarely would I do that. If I was talking about acute lung injury of patients coming in who had a standard pneumonia. So we were actually doing timely intubation on a number of folk, which is why within our institution, we had a significant number of patients. And indeed, you know, for the size of the population of the UK, you know, we peaked at 204 critical care patients in the second wave, as in 204 patients requiring intensive care. So we had to expand our intensive care hugely. Now, step that back, we still, in the second wave, didn't use non-invasive ventilation. We have a huge amount of experience in non-invasive ventilation, but we did have a tendency to use more high flow and high flow humidified oxygen in the second wave. But what I will say about any option you use, and the reason we use high flow is because, you know, your perception is that it will actually be better tolerated than a mask. I completely agree with that. That's the feedback from patients. But also it does come with the idea that, you know, if you have somebody who's developing hypercapnic respiratory failure, it will wash out some of the CO2. So you can oxygenate as well as clear CO2. The issue is you have to have a bucket load of oxygen in the hospital to be able to do this, as in seriously lots of oxygen. So I turned into the oxygen director of the hospital. I didn't go out for the job, but I knew how much oxygen we were using per day, and that's the thing that kept me up at night, because I just knew. So we had to take a view based on what resource we had. Could we put everyone on high flow? Well, no, we couldn't. That would have just immediately taken the system out. Could we put everyone on a ventilator? Probably could, because that only takes 10 litres per minute of oxygen. Do we have enough ventilators? No, but we did get enough. So this is a really complex question. I'm not avoiding the answer, but what I'm saying is you have to do it for the resource you have available. And if you do not have the ability to expand your ICU beds, then people will be moving towards using non-invasive respiratory support, either non-invasive ventilation or high flow humidified. However, if you have folk that you are not going to escalate, and I think this is really key, as in those who won't end up intubated because of frailty, because of certain underlying conditions, whatever it is that decision is made, then I do not believe you should be giving those non-invasive respiratory support, because we saw from our data the outcome was the same whether you gave them it or just gave them oxygen and then gave them supportive measures, and the outcome was the same, about 50-50 in each group. So they're the group that I think are obvious. The group that are going to get intubated, the obvious. Now the group you're going to talk to me about is the grey area where you aren't sure. And for that group, you would think about using high flow, but you have to make sure it's limited. I don't want people on increasingly fractionally inspired high flow, because the major problem with this is the self-induced lung injury and the idea that patients come in with an inflamed lung. On Saturday, I talked about, you know, the virus coming in, causing inflammatory response. When a patient comes in, they have a high drive to breathe, and you can see that. And whether that's driven by, you know, some kind of a brainstem action, but it's not necessarily driven by their wholly by their hypoxia, because you give them oxygen and they still have a high tidal volume. Now, that high tidal volume, when you've got an inflamed lung, is not your friend. And that is what we found, that patients who are on protracted periods, 7 days of CPAP, then got intubated, developed pneumomediastinum, pneumothoraces, and they're the guys that went on to have ECMO. And I don't, in the old days when I was growing up, acute lung injury, ARDS, was a phenomenon that physicians created. And I think some of this is there. So what you need to do is have a process, but I just implore you to do timely intubation if that patient requires it, which I know will depend on resource. And non-invasive respiratory support should be high flow if you have that ability to deliver it. If not, low flow oxygen, because we did that in wave 1 and we still have significant outcome success. So that's a rather long answer. We did have protocols. I can share all those with everybody here. I can put them in the chat. So people are actually really guided, but this is a complex problem, which is why it's caused so much discussion. I'm going to stop there. Chetan, sorry, bring you in, and obviously bring Matt in, because this is a complex area.
This is complex, but very important, because what you just said is that if you try to prolong intubation for a patient, then you are going to probably land up into more trouble later. Especially for a frail patient or the patient that you feel is going to eventually require intubation. Because what I have seen, or what physicians here feel, that if you intubate a patient, he is not going to come back, and that is a myth, or that is a misconception that many of us carry. So it is very important to clear that out right up front, that the outcomes are 50-50, but you have to choose your patient wisely. So would you just like to clarify something on that? And then over to Prof. Matthew.
Yeah, and just to say, Chetan, that you know, we've taken over wave 1 and wave 2, and again, we just say this is a single centre. We took 875 patients with COVID to critical care, Of those 875 patients we've taken to COVID, to critical care with COVID. And I will say some of those patients were DNA CPR. So there was just, and that's early during the wave because you have more availability of beds. So, but when I looked at it, our overall survival of that group is 76%. Now you have to say that is, you look across the globe of outcomes, that is a seriously impressive result when we intubated and ventilated so many folk and were proning so many folk and all those things. But you need resource to do this, and I can't say to you, every leader, and I do go back to leadership, needs to look at the resources they have, ventilators and oxygen, and decide how they're adequately going to use that resource. And I think that is the key element here. And again, I can give you lists of where we had cut-off points of patients we wanted to take to the ICU or we didn't, in terms of their oxygen levels. And I can share those afterwards, so Deep can share it with the assembled audience.
That would be great. And I really am impressed by the outcomes that you have. That's really awesome. So over to you, Prof. Matthew. What is your take on it? And the next question would be, in a resource limited setting like ours, now that we have more oxygen concentrators, how best to use them?
Yeah, so would it be possible to share screen? Can I have permission to share my screen? Because pictures and graphs is probably what you need. Let me know when you've given me permission. Essentially, I think I've got nothing to add to what Nick said. He's absolutely on the money. And I completely concur with that management strategy for patients. You wait too late, it's over. And picking your substrate early about who you're going to ventilate is really important. Those conversations about limits of treatment where necessary are critical. I think the other key element, and certainly the field that I've been most interested in, I suppose, has been this area of COVID oximetry in the own home environments. And as you can see from the data, when you get in early with home monitoring and admit patients in a timely manner using pulse oximetry, you not only improve the length of stay, the mortality rates quite significantly, but you also appear to have quite an interesting impact on the intensive care admission conversion rate. So the point is, don't wait till it's too late to admit a patient to the hospital, as well as the intensive care unit. Get them in early. If they're deteriorating, get them in early if you can. And that is engendered by actually having a whole system that fully works in all areas. It is not limited to the hospital. This is a far-reaching system that has to reach out into the community. And it's only by getting into the community at an early stage that we can really have the impact of actually admitting patients who are salvageable and not past the point of saving. Because it doesn't matter how fit you are, if you admit them too late, you can't save them. So the question is what that index point is within the resources and within the situation of different countries around the world. And if we can start impacting on that and start influencing the odds ratio of both death, intensive care admission, and length of stay, then we increase the flow through the healthcare system, which is the goal here. It's about meaningfully protecting patients, but also protecting the system to enable it to function at full capacity. And by the time we get to the point where if someone has got significant deterioration, I think one of the key elements is the timeliness of the admission, something we can only influence through putting in better strategies in community settings. In terms of what you do if you are completely overwhelmed, and this is something we didn't have to step up in England, but we were on the verge of stepping up in my particular region, was using 10,000 bedded units for potentially low acuity admissions. And I know parts of India have already considered this in cricket stadia. So the question therein is, do you use those facilities to admit low acuity patients on oxygen concentrators, potentially with dexamethasone or low molecular weight heparin, to cope with patients that might not require ventilation or might be deemed unsuitable for ventilation, even in the event of significant deterioration? And whether by doing that early, you can nip in the bud the significant deterioration that then occurs. And experience from China in Wuhan in the Fangdang hospitals, which were 13,000 bedded, is extremely positive. and slightly different from what the NHS did with their large hospitals, but something worth thinking about. And, you know, I would strongly urge you to reach out to them to get some advice on what they did in the midst of their massive pandemics, because their outcomes are pretty impressive, from the thousands and thousands of patients they admitted to those lower acuity areas. And then devising a pathway that actually allows you to do a low acuity admission, potentially in areas without intensive care, and saving those intensive care hospital admissions for those who are most likely to deteriorate and are also most suitable for full escalation and intervention.
Prof. Matthew, we can see your screen. So if
Yep.
you want to go over some of your slides and emphasize some important points. And from the audience, there's a question saying that there are many cases of young patients suffering from severe lung damage in the UK. And what could be the underlying reason? Because generally what we attribute is that what we see of a sick COVID patient is a diabetic, hypertensive, more than 60-year-old who comes into the ICU, and we don't expect a young person to come. So is there any underlying pathophysiology that puts a young patient at risk of being very sick or being affected?
So Matt, shall I? So the young, Chetan, the young folk we saw, and I will focus on the young folk that ended up coming through the ECMO service, but we didn't find any pre-existing, you know, necessarily pre-existing illness with these guys. There was a degree of obesity, and this needs to be taken into account. And on Saturday, I talked to the pulmonary mechanics changes you get with obesity, and especially with truncal obesity. And what we have to imagine is that the way COVID, and these points are really, really, really important to understand, but COVID causes an inflammatory lung condition, and that inflammatory lung condition can be worsened by your breathing pattern. So I've just talked to you about big tidal volumes. You know, I remember the first patient that early on in wave one that we intubated early on. And what I was expecting at the point of intubation was I was banging the patient. I just thought they'd be stiff lungs. You know, I just preconceived what I had because this was acute lung injury, and they weren't. They were the most compliant, inflamed, horrible lungs that I needed to protect from anything further damage happening to them. And again, that's the same process when you're talking about people that are obese, because when they lie down, I say about functional residual capacity and closing capacity. And when your FRC is below your closing capacity, that means your airways, your small airways close, but that is before that will occur earlier on. And if your airways close, small airways close, and they open again during inspiration, close and open, you're causing a huge, again, these changes, and you'll cause gas trapping as well. So all through this is stuff that we know already in terms of what happens with lung disease and acute lung injury. But obesity was what we saw very much prevalent throughout both waves. And walking through the units, and like many others, we had significant, you know, units and lots of patients who were lined up, and literally the demographic was the same. So everyone's saying, oh, there's an ethnicity drive or whatever, but it wasn't. It was the truncal obesity, and you could see folk, and underneath kind of the gowns they were wearing, you could just see a tummy sitting up. So it wasn't they looked overall hugely obese, but it was this part here. It was definitely that centripetal obesity that caused the problems. And not surprising, because that reduces your vital capacity, that reduces, again, with the whole idea of the airways, and then further damage being caused. So I'm not surprised with the folk that we saw coming through with, you know, diabetes and hypertension. But as regard to the younger folk just got poorly. Now, whether they had a large viral load, whether, you know, I don't, you know, that's all speculation on our part. But and they weren't large numbers, but there are a small group that came through.
Yeah, and I fully agree with what Nick's just outlined. And just to say, we did quite an in-depth analysis looking at different age bands affected throughout the pandemic. And what we saw was a steady decline in the average age, actually. So whereas it was still probably prevalent that 65 or over, or at the 50 to 65-year-old age range with comorbidities appeared to be the people that died most often, it was not limited to that. And that didn't reflect who we were necessarily admitting to hospital. So let me share this data. So we did recurrent analyses throughout, looking at what the average age of admissions were, both into our intensive care units, but also our general medical beds. And this is my particular region across the southeast, to really look at where we should put the line in the sand in terms of the at-risk group, both to inform clinicians across all settings, but also to determine who we did pulse oximetry on in the community. So in England, we bought around 700,000 oximeters to try and monitor people, to develop this strategy to reduce inappropriate admissions, but also expedite admission where people got critically ill. And then did the case analysis looking at the emergency admissions by age band, which steadily declined from a 65 plus age group to now what we're seeing is, which is the 40s to the 50s in terms of the average age. What this led to also was a breakdown to see what the critical care components were by age group. And again, that steadily declined throughout. And now we're seeing patients in the 40s as an average. It does make you think, the impact of vaccination, because obviously we've now vaccinated across England the 85, the 80s, the 75s, and the 60s, and we've seen almost a 93% reduction in the numbers of acute COVID post-vaccination, which is why it's such a vital component of this. But it has led to us changing our entry criteria of who we monitor and who we view at the at-risk group now to patients in their 40s instead of what used to be in their 65 plus. And in terms of how that then joins with the pathway, and this was the pathway I was alluding to earlier, if you are overwhelmed as a healthcare system and there's nowhere to admit patients who need an oxygen concentrator, it is something that potentially needs to be thought about in terms of where you can place someone and the potential use of alternate admission areas should the healthcare system be completely overwhelmed. I think this is in keeping with the national Indian recommendations in terms of the 90% mark. The question is how you use the resources that are available to optimally deliver the best outcomes for your entire population. And part of that is around admitting the right sort of patient in a timely fashion in the right sort of area. And in England, we found that a large number of patients were being admitted with normal oxygen levels. And that's not due to anyone's fault. We were feeling our way and learning. But what we have now got is a situation where those have rapidly declined because we know the absolute link between oxygen saturations at home and mortality and intensive care future requirements. And as soon as you start to build that data in from a local and regional and national perspective, you can start changing the pathways and the behaviors of entire populations.
Great. It is really good to see finally some data and some guidelines emerging based on the data, because I remember in the first wave, we were all just scampering in the dark, and now we have more data to suggest what exactly we should do, and that would be very helpful. So that's great. So there is one
Chetan,
way. Yeah,
Chetan, can I just comment, and I agree with you, and Matt's data is really helpful, and I think like a number of us, we've had data-driven clinical care as our central component of everything we've done. So we didn't make any decisions without having data to support it, like many others. And I listening to your resume and CV, I'm a researcher. I used to be. Now I'm basically a data analyst or a data interpreter and make clinical judgment. It's actually far more dynamic than the research I used to do previously, because it can really make a difference. Really, you see the differences. But what I will say, and Matt is quite right, understanding your local data is key. And you're going to think, gosh, we haven't got time to do this. But you need to make the time, honestly, because to understand the patients coming in, understanding what they're looking like, understanding who's going to whichever part of the hospital, who's being looked after, what their outcomes are, allows you to change what you're doing. Because at all times we knew we were doing things slightly differently to others, but we knew exactly what our outcomes were. So we were challenging ourselves, because you're right, you are in the dark, and the only way you can see a glimmer of light is knowing what the outcomes are. And that I can't say loud enough into understanding really where you stand. So just a key message.
Right, and that is very important, because I think for a country like India, where there is so much heterogeneity, people who have 10 ventilators and say 50 patients versus one ventilator and 50 patients would have a different strategy. And when they speak to each other, they will say that, oh, you're right or I'm right, and they will confuse each other more than anything else. So it has to be more of a setting driven approach to each center or to each community level hospital or a tertiary care hospital. That is how we should be prepared for in the third wave, and that's what I think should be done by pooling all the resources in different settings together. So I think that is where we should go.
Chetan, I completely agree with you and Nick. And actually, one of the things that really saved us, I think, was the network across England. Essentially, we talked to each other. We shared horror stories of what we were doing, what we'd seen, what had not worked. And actually learning what had not worked was one of the best ways of learning about what we should be doing instead, to be quite honest. And, you know, what we don't want to repeat is the same mistake in 100 different units. We want to learn from the 1 or 2 units that have had bad experiences and change. And we did this fantastically across the country, both in the intensive care environment, but also more widely in the community and also general hospital care. And I know you're already doing this, but these networks of communities of practice are where the most rich learning came from. Open learning, no blame, no sharing outside of there about the mistakes. So people could be honest about what hadn't worked, what they wish they had done differently, and also ask the forum of what they should do based on the experience of others. There's a great deal of honesty, transparency, and generosity of that sharing. And that spirit is something we never want to give up, because it's taken us so much further than we could have achieved by being less sharing and keeping our mistakes to ourselves, which, to be honest with you, was the culture, I think, in some ways prior to COVID.
I think that's a very, very important point. And if there is one takeaway from the pandemic for everyone, all subspecialties, all specialties put together, is that sharing of information and learning from one another. So that is a very important message that is well taken. So now, just that there are a few questions coming on the chat, I would like to divert our attention to a few things. One is the role of this cocktail of monoclonal antibodies and antivirals that are there. And every time there is something new that comes up and people get excited and want to lunge onto it because people think, I don't have anything, I should try it. And that is where, how would you use your clinical discretion to use one of these monoclonal antibodies or antivirals? When would you use it? What level of evidence do you require to use it? And whether you use it, what is the point you use it, whether it is changing from mild to moderate or moderate to severe. This is for the monoclonal antibodies and the antivirals.
So I can go first. For the monoclonal antibody, I mean, the only one that we would use is, tocilizumab on license. And what I mean by on license is we have randomized controlled trial evidence that folk who were requiring oxygen that were given tocilizumab on day 1, and then they were given dexamethasone thereafter. So that is a clear pathway that we have followed. Within our institution, we did not give tocilizumab, the IL-6 monoclonal antibody, and for folk who are on the wards. We did not feel comfortable enough, and this was close liaison with our acute medicine folk and the ICU folk, that we didn't do that. We stick to dexamethasone outside the critical care, and then we were using biologics inside. And the other one we used was obviously anakinra, but that was off license, and we used that almost to terms of folk, and that was much earlier on, as more salvage. So we did use these, and we used it as soon as recovery came out. We started using it. So now we're looking through our data because, as we said previously, multi-drug resistant organisms are a real concern, but multi-drug resistant organisms are driven by any immunosuppression and any environment that doesn't have what I would call satisfactory infection prevention control. And when you've got 25 critical care patients in a 15-bedded unit, it's not quite perfect, and we follow a certain set of standards, and we're breaching all of those standards by doing this. So you do have to be careful about multi-drug resistant organisms. Ours was very much more about gram-negative resistant organisms that we had, and saw some organisms, as I said previously, that we don't normally see in our institution, Acinetobacter, Stenotrophomonas, and we haven't seen them because we have very good antibiotic stewardship. So yes, these drugs are useful, yes they work, but the target population that you use these biologics in has to be clear. If tocilizumab is given, the patient then needs to be given a letter that they go home with, and that letter then goes to the GP saying they've had an immunosuppressant agent, and this may have effects further down the line to them. So they're not without a complicated regime for delivery.
Nick, completely agree with Nick in the hospital-based environment. Absolutely right. And just to add, we are looking at quite a number of different treatments in the community pre-hospital admission as disease-modifying cytokine storm reducing drugs. And unfortunately, thus far, we have found nothing that does the job. The other element of it is the pragmatism of actually how you get infusions of monoclonal antibody in relatively well patients in the community. It's a very tricky thing to do, and you need really strong evidence to prove that there is a disease-modifying treatment that works. So it isn't coming at the moment for mild or even moderate patients. As Nick says, it's definitely reserved for the more severe end.
Right. So I think now that India is seeing a lot of nuclear cases, people are now questioning how much Dexa was given, why Dexa with so many antibiotics. So I think the medical community has also learned its lesson to go by evidence rather than just by whatever new drug comes in and lunging onto it, rather than waiting for a credible evidence before using it. So I think that is something that we have learned during the pandemic, and that will be a lesson that we carry forward.
Sorry, can I just come in on that?
Yes,
just because
go ahead. Yeah.
There was a really interesting paper in the Infectious Diseases Journal recently that showed that patients coming in with COVID only had around a 6% chance of having superadded initial bacterial infection, complicating their COVID presentation, most commonly in pneumonia when it was present. The point being, in England, 100% of patients coming in got antibiotics, and 94% of them probably didn't need them. So, I suppose the lesson is, instead of starting everyone potentially on blanket antibiotics for strongly suspected COVID, potentially holding fire and waiting and seeing. Because as you know, the evidence for 1 hour antibiotics in sepsis is extremely limited anyway, for even bacterial infection. And we should be pausing and thinking where a patient is not in extremis or critically unwell. And I think that also goes with COVID. If you have strong suspicion this is purely viral and COVID as opposed to a bacterial infection, then perhaps wading in with broad spectrum antibiotics is not the right thing to do on entry.
Right, very, very important point. And I think that antibiotic stewardship programs will, as we learned from the pandemic, they'll be built all over the country, and we will adhere to those more vigilantly as we go forward. So now that we have a little less time left, I would like to ask this question. What are the most important things for the healthcare system now? Especially, we have now time to prepare for the third wave. So now, before the third wave, how do you think the hospitals should prepare themselves? And considering that not all hospitals will have ventilators, but we might have enough oxygen concentrators. So how shall we go ahead, especially in the Indian setting that now Prof. Nick and Prof. Matthew, you know some of the scenarios that go on in India. What do you think would be the best bet for probably a tertiary care center and a secondary care center and a primary center?
So, Chetan, I'll just start off. We have been planning a third wave before the end of the second wave. I had to sensitively raise this into a group of senior clinicians and managers in our own institution, in the sector, because I think there was, after the first wave, the flags went out and everybody thought, this is it, it's all going to be sunshine. And those of us who were not necessarily of that thought really had to work hard for people to recognise that a second wave was coming. And I think that's fair to say it was very difficult in the UK to really get that highlighted. Now, because we almost did it to the day of when we said we're going to peak in our institution for the wave 2 based on modelling, because we've got a lot of modelling support and, again, my previous life of doing research. But what the key element is to start to, as you come down out the second wave, you just need to sensitively start to discuss this. And it really is a hard thing to discuss because people just can't actually envisage it. But what we've done, we've come up with a surveillance system. And the reason we've come up with a surveillance system that's local is that the national predictive models are based basically on R0 and different scenarios and all these things. Everybody's got a confound of whatever your predictive model is. But if you have your own and you own it and you know the data, you're going to be better off. And so again, it's that whole idea of, yes, being part of a bigger organisation, which we are, which is NHS London, but locally we're just trying to understand and doing this across the region, across the sector. So the reason I'm saying this is, so we actually swab everybody coming in for an elective procedure. If you're coming in for an operation or dialysis or whatever it is, we swab you because you need to be PCR negative for at least 72 hours before you can cross the door into our hospital, because it's our way we limit infection. Now, what we do is they are marked as asymptomatic swabs. Now, we monitored those asymptomatic swabs during wave 2. And in fact, by the 19th of December, which is when we hit our exponential growth in terms of we were lighting the fuse, as I've highlighted, and then the exponential growth, we were 5% in our positive asymptomatic rate. So 5 in every 100 of patients in the community who are supposedly absolutely fine with no symptoms had COVID. Now that for me made us worried, but we didn't know necessarily what that meant. What we've actually got now, and I can tell you today, we're at 0.1%. As of today, we're at 0.1% of our asymptomatic swabbing is positive. So we know when we hit 1.5, based on the previous data and the way we've modeled it, we've got 31 days until exponential. If certain other criteria are hit, so we know what that data, if you end up with a rolling average over 5 days of greater than 5 admissions of COVID per day just through the ED, that gives you 31 days. If you have 20 patients in the ICU, an occupancy of 20 patients in the ICU, you've got 31 days. And so we now know these 3 triggers. Now, if they don't, because that says community disease to hospital disease to ICU disease, which, because they're all related. Now, if we see community disease, but because of whatever, and I won't say vaccination because I think my concern is those who haven't been vaccinated, because they'll behave exactly the same wave 1, wave 2, wave 3. Why should they behave any differently? Because they will, because they haven't been vaccinated. So, but we'll be monitoring those in the community who are asymptomatic positive. Those coming through, is that converting to folk coming through the front door at 5 per day on a 5-day rolling average? And is that converting to an occupancy in the ICU of 20 patients greater than 20 patients who are COVID positive over a 5-day rolling average. And the reason for do 5-day rolling average, as we know, it makes the grass nice and smooth. So you actually get a better understanding. So we've done that. So if you can know what's going on in the community, you know what's going on in the front door coming through ED, and you know what's going on in your ICU, you can then start to predict. And the reason I like the idea we've got 30 days or 31 days is we can start telling staff to take holiday. We can start telling staff to get some downtime because we've got something ahead of us. A bit like we would do for winter. Every half term in October, everybody takes time off because we know we've got catastrophe, you know, whatever you try and do, it's always catastrophe. At least we've got modelling out to know how many patients we think are coming through, whereas before we used to do that quite a lot, stick our fingers in the air. So but it's really key that you have systems in place that you feel are helpful to you. And yes, we have done the third wave model for us. And it's really important to look at on what we did. We looked across Europe and we looked at Spanish flu, because Spanish flu actually is completed pandemic. So you know it's finished. But what you always say is the third wave is never bigger than the second wave. I haven't seen single evidence to show the third wave is bigger than the second. It can come pretty close, but it's not bigger. Now, that for me is all the reassurance I need, because I think when you say you're going to go through another wave and it's going to be bigger than the second wave, then that makes healthcare teams really struggle. So a very sensitive approach, a very thoughtful approach, a very balanced approach, which is data driven. So folk understand we are not raising a red flag to make everybody absolutely uncomfortable and unsettled, but we're actually planning. And we have planned already. We've got ventilators ready to go. We've got these things called load hogs. So there's the ventilator, the monitor, all the syringes, all the syringe pump, blah, blah, blah. And they're all ready to go if we have a spike. So, you know, all of that is prepared for us. And we've got 100 of those in case we need to go. And that's, for us, it's converted to critical care space, because that's where I'm kind of living. But that's our approach, which again has come from a lot of discussions over the last 18 months.
Great. I think that was very reassuring to hear from you that the third wave is not going to be worse than the second wave. So I think that is that will make many of our audience feel a little better. So that is a point well taken. And needing to prepare is something that I think is very important. So we have to see the local data and see how it pans out and be prepared. So for India, I think one of the things that we can see, the wave starts in a particular part of the country and then it spreads throughout the country. So the other places will have time to prepare. So I think we should take advantage of that when we come up with the third spike. And that 30-day preparation window is something that we will definitely look for when we look forward. Yeah. So
Chetan, I can't say how important non-pharmacological measures are. You know, we've used hands, face, space, and I just can't get across that wearing a mask, washing your hands, and making sure you're socially distanced is so key. And even those of us who went through that and got COVID, as I did, you know, it's not going to protect you, but it's so much more important than thinking that healthcare is going to step in, manage you, and save you.
I think that again has been emphasized again over and over again. Social distancing becomes a little challenging in India, but definitely people can mask and make sure that at least they don't crowd in places. So I think that is something that with the numbers and the media that has gone through, people will definitely be careful as we go along. And I thank you very much for all that you have shared, because this is the crux of how we do go ahead to face the next wave. Prof. Matthew, any thoughts?
Difficult to top what Nick said, because I think he summarized everything so beautifully. I guess what I would implore people to consider is more joined up collaborative thinking across the entire care pathway. for the reasons Nick said about, I guess, the preventative angle. I think hospitals liaising with communities that they serve is really important going forward. Informing communities of what sort of patient they want to be seeing at what stage of the illness is really important. And I think forging the link in terms of the development of pathways of care is a critical core component. So what COVID has taught us is, in some ways, this kind of model of an iceberg. So we've dealt with COVID, I guess, in this remote way. A load of countries are still going through very, very large numbers, and parts of England as well, to be quite honest. And the question is how we then turn this model into what we will face in the future, both in terms of acute care, chronic care, post-discharge care, and elective care. And then start thinking, okay, so third wave is going to come. We don't know how big it's going to be. Therefore, instead of having a whole section for virtual care being COVID, why don't we instead tackle syndromic pathways of acute presentations? So what's the recurring theme we get every winter? And it's people who come in breathless and with breathing type disorders. So if we develop a breathing syndromic pathway that could also cope with COVID, we are future-proofed for third wave, and we are future-proof for winter. And winter happens every year. By doing that, we also hark to what people really notice and how patients actually present, because they do not come with a diagnostic label. They come with a series of symptoms and a rough ballpark of what might be wrong with them. And actually, those principles of care in that virtual environment between acute care, chronic care, discharge from hospitals, elective care, all share similar elements that can be shared as a general principle for how people can be managed in order to protect patients and also protect the healthcare system. So my closing note would be collaborate across all silos and settings with patients, with the general public, with politicians, with religious leaders and communities to make the most use and the most appropriate use of healthcare facilities should they be required, so that we are not overwhelmed in third peak with patients who should not be seen in a hospital.
Great. I think really this is, we are discussing about the way forward, and this is very important. I would like Prof. Nick to cover in the next topic, whenever you have the next webinar. I would like you to cover some of the aspects of what are the late effects, if you are seeing any, of the patients whom you have treated now, or the first wave and second wave, and about reinfections and how to be aware of those, or how to pick them up early so that we avoid some of these complications or manage them early.
Yeah, and I think Chetan, that will leave us into discussions as well as you see more and more of this of long COVID as well, which is something else we've had to put our arms around, embrace, understand, and deliver pathways. And I appreciate your just coming down the other side of the mountain as it is, and you're hopefully coming down the other side. And just to say, all I remember is quite a long way down. And now you have to start thinking about wave 3, but also you have to think about all those long COVID folk that we need to look after.
Great. As I see the clock, it's just a few minutes left, so I will hand it over to Deep. Take it from there. Thank you very much, everyone, for joining us, and it was great learning from Prof. Nick and Prof. Matthew.
Thank you so much, speakers and moderators. So it is just for a disclaimer for all our audiences that the clinician to clinician information, these knowledge exchanges session contains general information about medical condition and the treatment. The information is not formal clinical advice and should not be treated as such. The medical information provided without any representation or warranties, express or implied. We, the NHS, make no representation or warranties in relation to the clinical information offered. You must not rely solely on the knowledge exchange sessions as an alternative. If you have any specific questions about any medical matter, you should consult other professional healthcare colleagues. It is important to understand NHS healthcare professionals are providing their NHS experiences and their knowledge on the management of COVID-19. The duty of patient care will remain the responsibility of colleagues or clinicians in India. NHS organization, NHS bodies, NHS workforce will not take any direct or indirect responsibility for patients not under their direct care or supervision. Thank you so much. On behalf of all of our viewers, participants, the organizing team, and British High Commission India, I would like to extend our sincere gratitude to our speaker and moderator. Thank you so much for joining us here today and spend your precious time with us. We hope to see you in future and wish you all the very best. Thank you so much.
Thanks, everyone.
Thanks, Deep. Thanks, Chetan. See you later, Matt. And see everybody next Thursday.
Yeah. Thanks a lot, Nick.
Bye.
Dear participants, I wish to announce that we are holding series of webinars on every Saturday at 6 p.m. If you or any of your colleagues wish to learn more about COVID management, I would encourage you to join our session on Saturday in the same channel. For next week, our topic will be reviewing the evidence for and against of the most common prescriptions. With this, I think we call it a day. Thank you so much, everyone, for joining today. Have a good evening. Thank you. Bye-bye.